Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we explore rapid syndromic testing for bloodstream infections. We'll learn how to apply best practices for diagnostic and antimicrobial stewardship in syndromic testing. I'm joined by Dr. Emily Heil from University of Maryland School of Pharmacy. To follow along with the slides, please visit the show notes for this episode. Now let's get started.
So here's our roadmap for today. So we'll be identifying what patients are good candidates for blood cultures, the benefits of rapid diagnostics for organism identification, and how to optimally integrate these rapid diagnostics into your hospital workflows with corresponding treatment guidelines and communication to lead optimal treatment decisions for your patients. So bloodstream inspections, which is by definition the presence of bacteria in the blood, also known as bacteremia, can really cause devastating disease. It can result in sepsis, and it's associated with a high mortality risk. The resulting clinical manifestations can range from asymptomatic or minimally symptomatic transient bacteremia all the way to bacteremias causing severe sepsis and death. Transient bacteremia is usually triggered by manipulations of the mucous membranes, such as dental or urinary procedures, or even simple daily activities like toothbrushing or bowel movements. In the middle of the spectrum, we have bacteremias that are associated with localized infections, such as pyelonephritis or community-acquired pneumonia, without causing severe sepsis. In many of these cases, detecting bacteremia does not change the management. For example, you're still going to treat a patient with community-acquired pneumonia for 5 to 7 days, independent of their blood culture results. Blood cultures are therefore of the highest value for patients where there's concern for sepsis or endovascular infection. And blood cultures allow us for organism identification and antimicrobial susceptibility testing to help us optimize our patients' antibiotic treatment. Blood cultures are a gold standard for diagnosing bloodstream infections. And like many diagnostic tests, they need to be done well, or the results can actually cloud the clinical picture. So you may hear people talking about getting good blood cultures. So when we're talking about getting good blood cultures, we're generally referring to adequate aseptic technique and adequate volume. So having enough blood is a major determinant of blood culture sensitivity. So we want 2 sets of blood cultures for an adult patient. That's actually 4 of those hot sauce bottles, 1 aerobic and 1 anaerobic per set. And each needs to be filled with 10 milliliters of blood. So that's 40 mils of blood for a good set of blood, good 2 sets of blood cultures. These bottles are often inappropriately filled, most often underfilled, and up to 40% of blood cultures are just sent as 1 set instead of the recommended 2 sets. And in addition to getting the blood cultures drawn correctly, we also want to make sure that we're drawing them in the right patients. When blood cultures are overutilized or obtained on patients without high clinical suspicion of bloodstream infection, there can actually be negative consequences. Most commonly, we worry about the risk of contaminated cultures leading to false positive results. This can then lead to subsequent unnecessary antibiotic use and further unnecessary blood draws or diagnostic tests to ensure that the results were in fact just contamination. All of these blood draws contribute to hospital-associated anemias, and if cultures are being drawn from a central line, improper technique can actually increase the risk of infection. All of this can also increase the patient's hospital length of stay. It might delay or cancel other procedures they have and cause unnecessary patient discomfort. Now, this must be weighed against the risk of not getting adequate diagnostic information in patients with true bloodstream infections, which can also have significant consequences. So, how are we able to utilize diagnostic stewardship to make sure the right patients are being selected for blood cultures? A large portion of blood cultures ordered in the hospital are to evaluate fever or leukocytosis, both of which have been found to actually correlate relatively poorly with bacteremias. So while it's encouraged to not pan-culture patients presenting with fevers, we do actually lack guidelines specifying when to draw blood cultures for the initial work of a patient, and also when we should draw blood cultures to document the clearance of a known bacteremia. So there are some questions that we can ask to help us guide the process, including, does the patient have an infection that requires blood cultures? So patients with sepsis or septic shock, absolutely yes. Are patients presenting with an infectious syndrome that has a moderate to high risk of concomitant bloodstream infection, like infective endocarditis or meningitis? Absolutely yes, then we should be getting cultures. However, just getting blood cultures for the presence of fever or leukocytosis might not be necessary pending other clinical findings. For example, in a non-septic patient presenting with symptoms of a urinary tract infection, really just urinary cultures are really all you need, and this patient probably would not benefit from getting blood cultures. So what about repeating blood cultures for patients with a known bacteremia? For Staph aureus bacteremia and candidemia, or a patient with an endovascular infection, we absolutely want to get those repeat blood cultures to demonstrate that the patient's cleared their infection. However, for many gram-negative organisms and things like Streptococcus pneumoniae, we don't always need repeat blood cultures if our patient has adequately responded to our antibiotic therapy and if they've achieved source control for their infection. So, how might we integrate these decisions into our clinical practice? The first thing to do is to audit our current blood culturing practices at our institution to understand where our issues might lie at baseline. For example, is the issue really at the time that the cultures are being drawn, and do we need to educate phlebotomy about aseptic culturing technique? Is it that we're actually over ordering patient cultures in patients and doing more of like a ICU fever pack where everyone gets blood cultures? We additionally want to observe that blood culturing practice to identify barriers to improvement. Again, making sure all of our staff responsible for blood cultures are using appropriate aseptic technique, and that we're providing education on how to provide and obtain those good cultures we talked about in terms of the optimal number of bottles of blood cultures, optimal filling volume, and contamination reduction strategies. This can be something that lends itself well to the implementation of like an algorithm or a decision support tool to inform when initial and repeat blood cultures should be done at the time of blood culture ordering based on pretest probability of bacteremia and host characteristics. And when this is done in conjunction with end user stakeholders and hospital leadership, you can see a real impact in culture utilization. So now that we've established how to optimally order blood cultures, let's transition to the workup of these cultures in the lab. When a blood culture is positive, a cascade of additional diagnostic tests begins, including the gram stain, the results of which are typically phoned to the team caring for the patient, and then subculturing of the blood to solid media so that the organism can be grown in pure culture. We can identify bacterial colonies and then do our antimicrobial susceptibility testing. Antimicrobial susceptibility testing is performed by exposing the bacteria to like a panel of antibiotics and observing if growth is inhibited. And in most laboratories in the US, this is done with automatic instrumentation. There are additional manual techniques such as gradient strips or disc diffusion that might be required to confirm some results for antibiotics not available on our standardized assay panels for our automated systems. And although we've had a lot of advancements in culture media and these automated testing profiles that have improved the sensitivity and turnaround time of blood culture results, they are still inherently hampered by several limitations that can make it take up to 5 days to get full identification and susceptibility for our bacteria. And so, in the setting of something like contamination with skin flora for our cultures, this can really delay our timing of understanding what is truly happening for our patient. All the while, these patients might be continued on empiric broad spectrum antibiotics rather than the optimal targeted therapy that we would like to have a patient on. So, the advent of rapid diagnostic tests for bloodstream infections can really supplement our traditional culture and susceptibility testing methods and allow us for earlier optimization of our antibiotic therapy by providing early species identification and also, in some situations, even identify the presence or absence of specific resistance genes. There's even some technologies that can provide early preliminary susceptibility results. These rapid diagnostic testing methodologies are recommended by the American Society for Microbiology to reduce the time to targeted therapy in patients with positive cultures when utilized in combination with active communication of the test results. So we know that delaying time to antibiotic therapy and optimal or appropriate antibiotic therapy in patients with bacteremia is associated with an increased risk of mortality. We also know that excessive or unnecessary antibiotic use can increase a patient's risk of having antibiotic resistance. So, therefore, having more information about a patient's cultures as soon as possible can really help us to not only get the patient on active therapy earlier in the course of treatment, but also help us to optimize our treatment by targeting therapy to the specific organisms or resistance patterns that we're detecting rather than just continuing patients on broad spectrum coverage. So, rapid diagnostic tests are going to provide us with this information, and when used in conjunction with antimicrobial stewardship oversight, has been shown to decrease hospital length of stay and costs associated with that hospitalization. The field of rapid diagnostic microbiology really relies on the identification of either microbial specific proteins. An example of this would be MALDI-TOF, which stands for Matrix Assisted Laser Desorption Imaging, time of flight mass spectrometry, a whole mouthful, or nucleic acid technologies like the multiplex polymerase chain reaction PCRs, microarrays, or probe-based fluorescent microscopy. Of all of the different rapid diagnostic tests we have available, the MALDI-TOF has been the most widely adapted technology in recent years and really the most variably applied platform for the identification of bacteria and yeast based on each pathogen's unique protein profile. So again, this technology involves the ionization of organism proteins followed by the measurement and comparison of their mass charge ratios against that of known organisms in this massive database. So the ability to detect over 400 pathogens in as little as a half an hour is something that we can achieve with MALDI-TOF, although it is unable to detect the presence or absence of specific resistance genes. There are also several clinical methods to identify microbes by nucleic acid detection, including DNA sequencing, multiplex PCRs, microarrays, and those probe-based fluorescent technologies. So a couple of examples I'll highlight. The BioFire is going to extract and purify nucleic acids from a positive blood culture and perform a nested multiplex PCR to identify bacterial species and certain resistance genes. The Verigene is going to use magnetic beads to capture bacterial DNA to rapidly identify bacteria and resistance gene markers. And the Cobas ePlex from Roche is also a multiplex PCR system able to identify bacterial species and certain markers of resistance. All of these have identification times ranging from as little as 30 minutes to up to 3 hours when the test is run once a blood culture has turned positive. Now, the T2 Biosystems emerged as the first FDA-cleared diagnostic test to identify pathogens actually directly from whole blood. And so this technology works by combining PCR technology and magnetic resonance imaging using probe-enriched superparamagnetic nanoparticles. So removing the need for blood cultures can actually really decrease the time for the results. But of course, with a test like this, you really want to have really high pre-test probability that a patient has bacteremia to steward the utilization of this test. And then finally, the Accelerate Pheno is also a little bit unique as it uses automated fluorescence in situ hybridization to identify bacterial and fungal species, but it also does rapid antimicrobial susceptibility testing within 7 hours using morphokinetic image analysis to predict the organism MIC. So this is just an example of all of the amazing rapid technologies out there that we can utilize to help decrease that time compared to our conventional methods. Now, from a stewardship perspective, we think a lot about how these tests might help us target getting patients on more targeted, narrow spectrum therapy earlier. But these tests don't always necessarily mean de-escalation of therapy. And actually, one of the major benefits of these rapid diagnostic tests is that we can detect resistance genes, shortening the time to patients having appropriate therapy in multi-drug resistant organisms. So for example, many hospitals, are going to use an empiric anti-pseudomonal agent like piperacillin tazobactam in a patient presenting with sepsis. But if a patient's rapid diagnostic test shows that they're harboring an organism with a KPC carbapenemase, then their antibiotics can be quickly broadened to something like meropenem vaborbactam or ceftazine avibactam. So it's helpful to implement these tools in conjunction with some specific guidance about what to do with the results. So this gets to the important question of, if a tree falls in the forest and no one is around to hear it, does it make a sound? These rapid diagnostic tests provide us a wealth of information, but they're frankly not going to be as useful unless there's active intervention to implement the results. And this data comes from two big meta-analyses. The first was from 2017 and found decreased mortality and length of stay when rapid diagnostic tests were used in conjunction with an active antimicrobial stewardship program, but not in their absence. This was updated in a network meta-analysis from 2024 that identified that the time to optimal antibiotic treatment was decreased by 29 hours in patients who had rapid diagnostic tests plus that active antimicrobial stewardship intervention versus just normal blood culturing practices alone. But also, you only saw a 12-hour decrease when the rapid diagnostic test was used by itself, emphasizing that yes, these RDTs are great, but it's that active communication by a trained professional like someone from an antimicrobial stewardship team that's really going to make that big difference in our outcomes. They also found reduced length of stay for rapid diagnostic tests when combined with stewardship, but not when the rapid diagnostic test was used alone. And finally, they found decreased mortality when we utilize these rapid diagnostic tests in conjunction with stewardship. But again, that in conjunction with stewardship was what really made the difference in seeing the improved clinical outcomes here with these testings. So don't invest all this money and time into these great technologies without being sure that you have active communication of the test results by someone with expertise in what the results mean to help guide the patient's therapy. So let's go over some considerations for implementing a rapid diagnostic test for bloodstream infections. So first, we want to think about education. You want to make sure that in addition to communication of these results, there's also some education available for the patients reviewing the results. Having guidelines and algorithms based on your local susceptibility data are key. Next, we want to think about our communication considerations. So who is going to be receiving these results from the lab and what will they do with them? Could they be sent by a secure messaging system directly to someone on the antimicrobial stewardship or infectious diseases team in addition to the primary team? Will you report the results 24/7 or only during daytime hours? You want to make sure that this result reporting is going to ensure that the end user can actually interpret the results with a direct link to those institutional algorithms or guidelines, along with the communication recommendations from the stewardship provider, so the patients or the providers know exactly what to do with that information. So, how these results are reported can actually have a significant impact on antimicrobial decisions, especially when you don't have 24/7 stewardship support available for real time review and interpretation of the results. As an example, there was a recent study in pediatric patients that found that the time to changing antimicrobial therapy was longer when the rapid results were reported at night rather during the daytime, because at night there was just inadequate guidance on what to do with the findings in the absence of having some additional information available in addition to that direct communication. So, from a lab standpoint, would these be processed 24/7 or done in batches? Ideally, with these rapid tests, you want them done in real time. You want the information coming out as quickly as possible, but doing it in batches can actually really improve efficiency for the lab and also be timed with when you're able to communicate those results with an expert to your team. Would you have them done at a centralized lab or a decentralized lab if your main lab is not on site? To steward these tests, we generally run them just on the first positive blood culture versus doing them on every single blood culture, unless the gram stain is indicating that there might be something different in that second bottle. But that's a good way to make sure we're being efficient and cognizant of how we use these tests. One other thing to consider is that your local epidemiology is really important to develop your treatment algorithms. So, for example, if you've got a patient that's got like an Enterobacterales and CTXM is not detected, can you safely recommend something like ceftriaxone? Can you say, hey, this patient doesn't have an ESBL producing bacteremia? You can use your local data to evaluate the rates of ceftriaxone resistance in non-CTXM producing Enterobacterales to determine if it's an acceptably low risk to facilitate de-escalation in those patients. And those algorithms need to be routinely reevaluated annually to ensure that your data is still recommending what you're doing as part of ongoing quality control. There are also a few more stewardship interventions to consider on reporting your test results. So, as mentioned before, having the stewardship team actively review and communicate those findings in addition to specific treatment recommendations is really going to be where you're going to get the most bang for your buck in optimizing antibiotic therapy. You can also, again, build out those specific treatment algorithms to help both when organisms are with resistance is identified to potentially escalate therapy, but also maybe to de-escalate therapy to something more targeted in the absence of resistance markers. And on the actual micro report, you can use nudges or interpretive comments to aid in this. So, for example, if you've identified coagulase negative staph, you could consider saying something in the micro report like, hey, consider contamination, with guidance on what the team might want to do for next steps. Cascade reporting is also a more passive intervention, often employed by stewardship to help alter prescribing practices by limiting the reporting of broad spectrum agents in the setting of a more susceptible organism and only reporting the more narrow spectrum agents in those situations. But all of these interventions will help ensure that you're really getting the most bang for your buck with your new rapid diagnostic test. So, in conclusion, back to our roadmap, we want to make sure that we're culturing the right patients, using those rapid technologies to get information quickly about what the patient's growing, and then in conjunction with our local treatment algorithms and our antimicrobial stewardship team, communicating out to our primary teams to get patients on optimal antibiotics as soon as possible.
Thank you, Dr. Heil, and many thanks to you, our listeners, for joining us. To view the full program on rapid diagnostic testing for topics beyond bloodstream infections, please click the link in the show notes. To get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.